have your card grade on with it.
No, it'll actually be a link in, no, actually I have 2 YouTube pages, but it'll be posted to JV Learning, the link will be. So you can just go under that chapter, click the link, and it'll pull up, there's like 6 of them, but it'll pull up all the links to it. So what we're going to talk about is we're going to talk about CPAP, and we're going to talk about the goal of using it in the field. We're going to talk about why we use it, the patients on which we use it, and the indications and contraindications, which is probably the most important thing. When to use it, when not to use it, the whole nine. Okay, so we're going to talk about some key terms. The first one we're going to talk about is the lingo, okay? One of the things we talk about is non-invasive positive pressure ventilation, okay? That includes anything from CPAP, BiPAP, and bag valve mask ventilation, okay? So CPAP, BiPAP, and bag valve mask ventilation. We're going to talk about the difference between each of those, okay? So what our goal is non-invasive. Remember, once we go invasive, we're worried about what? Infection, okay? That's our biggest problem once we go invasive with any procedure is infection. That's what we want to avoid, okay? CPAP is continuous positive airway pressure, okay? What this means for us is we're going to be using it at one consistent pressure, okay? So one consistent pressure all the time. CPAP is what we use in the field, all right? Then we have something that goes with that called PEEP. And I'll show you a video, it's pretty cool here in just a minute. What PEEP is positive in expiratory pressure, okay? This can be used on patients that are on a ventilator that's intubated, and now, and I need to add this to this slide, it also is used with BVMs. There actually is a PEEP setting on certain newer bag valve masks, okay? Which is particularly helpful in the instance of your head trauma patients, okay? And in any patient, specifically CHF, to try to keep those lungs open, okay? And BiPAP is bi-level pressure. That means we're using 2 separate pressures to bag this patient, or to ventilate this patient. The thing about bi-level pressure is, it is expensive. BiPAPs are not cheap. And we're going to talk about the differences between the two here in just a second. Okay. Everybody good with it? All right. So CPAP versus BiPAP. With CPAP, your pressure is continuous. One solid pressure all the time, okay? With BiPAP, you also have continuous pressure, okay? With CPAP, same pressure in and out, doesn't matter. BiPAP, you'll have 2 different pressures. You'll have an inhalation pressure, which will usually be 3 to 4 times higher than your exhalation pressure. All it wants to do is keep a little bit of residual pressure inside those lungs, okay? So 15 versus 5, so 3 times the pressure, okay? And it's measured in centimeters of water, which is an atmospheric pressure setting, okay? CPAP is used in the field, and BiPAP is used in the hospital, okay? And the reason BiPAP is used in the hospital, because it is expensive. This is a very simple device. It is what I like to refer to as a Ronco product. Anybody know what I'm talking about? Ron Popeil used to sell like the Showtime grill and all that stuff. You set it and forget it, okay? BiPAP is not simple at all. You have to change a bunch of settings. It's no different than using what we refer to as an SIMV vent, or one of those specialty ventilators that they use for like critical care transport. It's very complicated to set up, okay? CPAP really, like I said, set it and forget it. Does not need much monitoring at all. Once it's on, it's on. You just check it periodically. Your patient usually responds very well to it, starts changing, things work good for them. BiPAP, you constantly have to monitor this. You constantly have to pay attention to it. You may constantly have to change settings to make sure your patient's getting what they need. And again, at the end of the day, it all boils down to price. CPAP is way cheaper. BiPAP, good luck. Okay? Only time you'll see BiPAP on a truck is in critical care peds transport. Okay? When it comes to peds, they spare no expense. Anybody else, they're like, good luck. Alright, so CPAP, why are we using it? What is it for? This is a pressurized air continuously delivered throughout the entirety of the respiratory cycle. You get one pressure all the time. That's why it's so easy to use. Both during inhalation and exhalation, and it's like you sticking your head out the window as you're driving down the street at a constant speed. That's exactly what it feels like. Okay? Like I said, I have sleep apnea. I sleep on CPAP every night. It's the best thing since sliced bread, but I promise you, it is very weird to have that much pressure being forced down your airway while you're trying to sleep in the beginning. After a while, you just fall asleep like within 15 seconds. It's great. Okay? So when we talk about CPAP, it is non-invasive. Okay? It's on the external of the body. You're just pushing air in. But the tubing and everything has to be clean. It's very easily applied. It's no different than putting on a non-rebreather or what have you in your patient. It's very easily discontinued. All you do is pop it off. Okay? We can use it on CHF. This is a big change because it used to be we only used it in CHF. That was it. Now we use it on COPD patients. And remember, our COPD patients are asthma, emphysema, bronchitis, bronchiolitis, and pneumonia. We use it on asthma patients. We use it in near drownings. This is another big change because any fluid that's in those lungs we want to flush out. Okay? Remember, gas exchange only takes place through surfactant. You have to have surfactant and nothing else, otherwise gas exchange will not happen. Okay? And you're able to use it with other medications. So if you have the patient that's on a nebulizer, you can actually create what I like to refer to as the peace pipe. And you'll have your CPAP tubing, your nebulizer, you can use capnography in line with it, and the mask. And it's like this far away from the patient's face, what I call a peace pipe. But you have all these things in circuit and they all work together.
So they pretty much use one of those related
Mm-hmm. Oh yeah. Yep. And what this does is, this keeps the patient going until all the medications have their effect, and most importantly, this keeps the patient most of the time from having to be intubated. That's the biggest saving grace with this device is that patient doesn't have to have that tube put into their throat. That's what you want, is to keep them off of that. Patients don't typically die from the things they go to the hospital for. They die, unless it's cardiac arrest obviously, but they die from the infection that they get while they're in the hospital. Like I said, my dad's a perfect example. He didn't die from his heart attack. He didn't die from the stroke that he had after the heart attack. What he died from was when he was put on the ventilator, he ended up getting pneumonia. That's what he passed away from. Okay? So, this is an alternative to endotracheal tube intubation. Okay? We want to keep them off the vent, and this is why. Randomized trials have demonstrated that 70% of patients with severe exacerbation of COPD, so again, asthma, CHF, emphysema, bronchitis, bronchiolitis, and pneumonia, that receive non-invasive ventilation avoid being intubated. We want to keep that tube out their throat. 50 to 70% end up not being intubated. That's huge. Used to be back in the day, you ended up in CHF, something like that, we bag you until we had to put you down and intubate you. Now we don't have to do that. Paramedics that are trained to use CPAP for these patients in severe respiratory failure. There's an absolute reduction in tracheal intubation by 30% and an absolute reduction in mortality by 21%. So 21% more people are surviving. That's huge. That's 2 in 10. That's a big deal. Okay? And patients who don't get intubated, often, patients that do get intubated, are on the ventilator for a long time. You don't go on the ventilator for a day and come off. That's not a thing, especially if you're a COPD patient. Once you go on, typically you're on 5 to 7 days. It takes a while to wean you off. Okay? So, what does that mean for us? Positive pressure redistributes lung fields. So, we use this in conjunction with a couple other things to open up those lung fields, open up those blood vessels, push that fluid out. Okay? It also acts as a stent. You know, just like the stents that they use in your heart when you have a heart attack and they want to reopen a blood vessel, this is what's referred to as mechanical stenting. You use air to force it open, okay? It reduces the work of breathing. They ain't got to breathe as hard because the air is being forced down their throat, okay? It counteracts your body's intrinsic PEEP. So instead of your body trying to keep air in, it automatically keeps air in. It says it forces air down with every breath. You don't have to worry about that. So this is your blue bloater. Your person that has pursed lips because they're trying to keep air in, you don't have to worry about that because it already does it. When they do that, it means that they're working very hard to breathe. Now you don't have to. It improves lung compliance, okay? Yeah? Keeps the lungs open. It reverses atelectasis. Remember those dead spots or those areas that are stiffened? It blows them open. Somewhere for that air to go. Fixes collapsed alveoli. Decreases preload and afterload. What that means for the heart is the heart doesn't have to work as hard, and that's for your CHF patient. Okay? It makes a big difference because there's not as much fluid. All right? And then, of course, it fixes or decreases VQ mismatch. Well, that lung that was closed is now open. Only time you won't use this is in the instance of lung trauma. Okay? And again, gas exchange is fixed. That's what we want at the end of the day. All right, we talked about VQ mismatch, so I'm skipping through these real quick. We've already gone over all that, and I am going to post this here in a second to your JV Learning. Okay, it'll be under everything will be under Chapter 10 in JV Learning. So this week, all you will have is Chapter 10. That's all it is. One chapter. There's a lot of information. You'll have the homework, which will be 40 questions. You'll have a quiz, which will be like 30 questions over nothing but this. But trust me, you're going to want to go over that homework a couple times, and I'll even put a practice quiz out there over Airway because I want to make sure that you're going over it well. Because as we go from Airway into patient assessment next week, you're going to want to know Airway before we get into patient assessment. Okay? So when we talk about partial pressures of gases, this is getting into this here, PaO2. Okay? So it's basically saying how much of a gas occupies the same space as 100% of that gas. So at sea level, we live at what's referred, because we live at sea level here, we're actually 5 feet above sea level here at this location. If you go to Tybee, you're actually 3 feet below sea level. It's 760 millimeters of mercury. That's your unit of measure, and that's your normal atmospheric pressure. At sea level is 760. Air is 21% or 20.9% O2. Okay? So the partial pressure, you take that 760 millimeters of mercury times 0.021, which is your 21%, and that means that oxygen is 159 millimeters of mercury of your total air at any given time. Okay? That's how you figure out partial pressures. So what does that mean? It's a lot of numbers. What does it mean? Well, the difference in pressure between the high concentration and low concentration, moving from high concentration to low concentration is called what? We just talked about it. Anybody?
It's D.
Diffusion.
Yeah.
Yes. Okay. High concentration, low concentration. It's also referred to as a pressure gradient. So it has something to work against. Okay. Well, that partial pressure moves towards the area of low concentration until that balance, like I said, when we equalize those tanks, it's the same thing. Okay. High concentration to low concentration area. All right. So what happens is that pressure gradient causes O2 to enter the blood and CO2 to leave. We talked about that before. Diffusion and osmosis, right? So the reason that the O2 enters the blood is that expired air is 16%. So it's only 121 millimeters of mercury. All right? Remember, we only use approximately 5% of the air we breathe in. Okay? Well, I say 5%, but 16 versus 5. So it's actually about 25% of the air we breathe in. Okay? Room air has 139 millimeters of mercury. So the difference between these two is not that great. 121 versus 139. It's not a big difference. Okay? What that means for us is, as we're ventilating a patient, it actually only creates a small percentage of change but creates a huge difference. Okay? CPAP, this applies to CPAP because it changes the pressure gradient. Instead of having that 121 or 139, it actually has a slightly higher pressure gradient. So it forces against something that's fighting against it. Okay? CPAP, again, pressures with centimeters of water. Okay? So the pressure at 1 atmosphere is 735. Okay? That means that in total, it's a 2.25% change. If you think about that, say you're giving somebody a tip on $100. That's $2.25. Does that seem like a lot? No, when you talk about money, everybody gets in on the job, right? So 2.25% difference doesn't sound like a lot, but it makes a huge difference at the end of the day. Okay? Then the reason that makes a huge difference is you're, instead of fighting against that 139 that's normally in room air, you've actually gone above and beyond that. So you're forcing air in against a lower number. So it automatically is going to do what you want it to do because you have the pressure behind it. Okay? That forces more oxygen into the blood, onto the hemoglobin, moves around the body, and actually the end result is it gets more CO2 out. Okay? What you want to do with CPAP is you want to use this in conjunction with vasodilators. What vasodilator do we have for somebody that's in CHF or having chest pain? What do we use? What's our medication? No, aspirin's not a vasodilator. Aspirin's an antiplatelet aggregate. Okay? What medication can we give that will cause the blood vessels to dilate? We give it for chest pain. Nitroglycerin. Nitroglycerin. It is a potent vasodilator. So it opens up every blood vessel at the same time, causes you a headache, all this good jazz. But when that opens, we put them on CPAP, and now that fluid that was in the lungs has somewhere to go. So it blows everything out, gets it out of the way. So what it works on is a mechanical effect. Okay? It increases the pressure in the airway, thereby opening the alveoli, allowing for that gas exchange to take place. It literally stents the airway that are at risk of collapse. It extends the alveoli to prevent collapse during inspiration, and it actually keeps the alveoli open. Basically, more surface area, right? If you think about it like this. If I have a window that I'm trying to cover, okay? If you're using, for you firemen, hydraulic ventilation, right? The more area of that window we cover, right, up to that 80%, 75, 80% of that window we want to use, the more air we can force out, right? The more smoke we can force out. So if we maximize our pattern to cover more of that area, or using a ventilation fan, same thing. We maximize the amount of that doorway we want to cover to force air through and push other air out, or force air out, the more surface area we have. The more effective our positive pressure ventilation, or negative pressure ventilation in this instance, is going to be. Okay? That's exactly the principle in which that works. It's all about surface area. Okay? The more surface area of the lungs we can actually use, the better ventilation is going to be. Okay? So what I'm going to show y'all now is about the physiological effects of CPAP. And it reduces your work of breathing. We've said all these things before. Our protocol is, like I said here in Chatham County, that we put it on anybody that is in pulmonary edema, either from drowning or from CHF. We put it on asthma patients. You can open it. It's the asthma exacerbation. So if they have asthma or severe asthma that's not responding to your bronchodilators, like your albuterol puffer, things like that, we go ahead and put them on CPAP. Just open those lungs, blow them open. Okay? COPD that's failing, again, if they're not responding to your albuterol or your adjuvant or whatever you're treating with, put them on that. Pneumonia, same thing. We want to get that air where it has to go. Okay? So all these are within the new protocol for Chatham County. All right, namely Southside. But the patient has to be breathing. Sounds stupid, right? But if you force air down the throat of